So thank you. So we're going to continue on this afternoon. Our first speaker is Lisa Stewart from Picori. Like myself, Lisa got involved in her current career through a personal connection with her chosen field. She currently serves as a senior engagement officer at the Patient-Centered Outcomes Research Institute, which is Picori, where she connects the engagement and science teams and helps manage Picori's research portfolio. She's speaking to us today about using research to impact lives, which is something I would hope is the ultimate goal of all CF Canada-funded research. Lisa.
Good afternoon, everyone. All right, show me some love. Yeah. You know, it's hard to be the first X in the afternoon, so thank you for that warm reception. So I can mess up the easiest of technology and working things, so I got my crew back here who can always keep me on track. So yes, so my name is Lisa Stewart. I've been with the Patient-Centered Outcomes Research Institute, otherwise known as Picori, for 4 years. And I'll tell you a little bit about my story and journey once we get into the presentation. So I also have the benefit of coming after some very good speakers this morning. Wouldn't you agree? So I'm going to try my best not to be repetitive, but also with the understanding the more you hear something, the more something sticks. And each time you hear something, you may get a little bit something different out of it. So again, not trying to be too repetitive, but you may hear some common themes across the presentations. Also, what the title alludes to is not just impacting lives, like research to impact lives, but how does engagement impact the lives of those people who are participating as partners in engagement, in research studies. So, who we are and what we do. So Picori, I probably should have said this, but we are US-based, if you didn't know that. So we are an independent research institute that was authorized by Congress in 2010 as part of the Patient Protection and Affordable Care Act. And we are governed by a 21-member board of governors that is appointed by the U.S. Government Accountability Office. So we have no say in the selection of our board. And they represent the entire healthcare community. And you'll see that theme reoccur throughout the presentation. Our stakeholders are many, and they assist with our organization and provide guidance for our organization, as well as for the projects that we fund. We fund comparative clinical effectiveness research, shorthand CER. CER, I'm gonna make an assumption that some people in this room have no idea what that is. CER is the type of research that compares 2 or more interventions against one another to see what works and for what communities under what circumstances. So very different from efficacy research, different from public health research. So that is a very kind of unique niche that we serve and generated through a climate in the US healthcare system at the time where people really wanted to know how is research being responsive, or is it being responsive to the people it aims to benefit. So again, we seek answers to real-world questions about what works and for whom. So very pragmatic in its orientation. So how are we different from other research funders? Is that we are focused on answering questions that matter the most to patients. And we heard earlier today that when the term patients is used, sometimes it's used with a very kind of broad, inclusive hand. So for us, we define patients as certainly patients, consumers, as well as carers or caregivers, as well as patient advocacy organizations like Cystic Fibrosis Canada goes within our patient bucket. We aim to produce evidence that can be easily applied in real-world settings. So for example, if we receive a proposal and it includes as its comparators treatments or interventions that most people wouldn't have access to or are far beyond the standard of care, it's not of high interest. We want to make sure that this research can be used. And we engage, again, a range of stakeholders throughout the research process with the hope and belief that this will make it more likely that the research results will be put into practice more quickly. So this is just a quick snapshot of our research portfolio. We've, as of the end of March, we have funded nearly $2.5 billion in research. The purple or magenta arc around the circle represents the CER research. Again, that's most of what we do. But we also fund methodology. How do we advance the methodology of CER? How do we advance the methodology of engagement in CER? So we are very much interested in populations that have heretofore been underrepresented in research. And you'll see on the bottom right, our most studied priority populations represent those interests. In addition to the categories that are mentioned, we also have a priority on veterans, as well as a wider range of disability communities. So we're focused on conditions that affect large numbers of people across a range of populations, that place heavy burdens on individuals, families, and specific populations. And we also include, as a part of that, rare diseases. It's a very important sector for us. In fact, we have 5 advisory panels that guide different organizational streams, and one of our advisory panels is our advisory panel on rare diseases. So this is just a picture to give you kind of the breadth. So when we talk about stakeholders, we have a big tent philosophy. And so we are very much interested in including in our discussions everyone who might have a stake at the table for a particular issue. I'm thinking of fairly recently, you can see over here, we start off by saying payers, our system's very different. But just this week I had a call on a project that was a payer or insurance representative who was paying for an intervention on one of our studies, and he was working with a network of payers because this was a pragmatic study, multi-site pragmatic study, and their involvement was critical to getting the intervention going. So we're having conversations, and we're also, in my role as engagement officer, trying to make matches with other projects so that cross-learning can occur. So that on that call were representatives from an entirely different project, entirely different condition, but wanted to learn from this other investigator who had and is having success with engaging this hard-to-reach stakeholder community. So this is a model of how stakeholders are involved, again, throughout our organization as well as on the projects that we study. So they help us determine our research partnerships and make connections for us. We hold stakeholder roundtables to determine our research priorities. So when we're having targeted announcements, which many of them are now, to get to that point of deciding what is that research targeted announcement is going to be about, we convene stakeholder groups to help us get there and help us get to the actual question that we hope the research aims to answer. Again, in the conduct of research, we require that stakeholders are involved in throughout. Well, we're not prescriptive in what we say. We don't say engagement has to look like this because it's very locally specific and specific to the problem that you are trying to address. But we do want to see them involved, stakeholders involved as advisors and as research team members when that's possible. We also ask that patients and other stakeholders be involved in the dissemination and implementation. We heard some interesting examples this morning about it's not just about coming to conferences and you're talking to your own constituency, but how do you move outside that box? And again, finally, policy and practice. That's really what we're trying to do, is change practice, change policy. So the part of the organization that I'm aligned with is public and patient engagement. And our key priorities are working with stakeholder groups, supporting and enhancing engagement practice. And we do that by developing curriculum, developing tools and resources. And we're just at the cusp of completing, well, I don't want to get anyone's hopes up too high, but or move the timeline. But we are in the midst of doing a study of engagement within our portfolio to answer those questions that we talked about this morning. What's working? Under what circumstances? How do we consider something successful? How do we consider it valuable, but maybe it didn't hit the mark? So we are taking a deep dive right now in our portfolio to advance the science of engagement. We're also trying to come up with new and innovative ways to build support for dissemination. So on a project level, this is our engagement rubric. This is a resource that was developed by PCORI a number of years ago as a conceptual framework to think about how to approach or how you may approach engagement on your research study. So when we speak to investigators, we talk to them about, so how were patients and other stakeholders involved in the planning of the study? What are the activities that they're doing at the conduct phase and disseminating study results? And so if you go to our website and you pull down the rubric, you will actually find real-world examples to kind of plant seeds of possibilities of what stakeholders can do at each phase. We are, we've completed our scientific investigation of engagement on the portfolio, we will revisit the rubric and more than likely expand it to include more audiences with more current information about activities that we're seeing, particularly innovations. So I want to share with you, give you a sample of a few of projects within our portfolio. So PCORI funds research, but it also funds and supports building capacity to doing engaged research. So these are two examples. The first one was a project led by the CF Reproductive and Sexual Health Collaborative. And this group, and you'll hear one of the people who worked on this project tomorrow, Sandy Sufyan, who also sits on our advisory panel for patient engagement, speak to this project. But this is a project where they took existing training products that were developed by other engagement awards and adapted them to address the very real issue that teams have to be able to engage online. And so they created a best practice user guide for online engagement, and by performing key informant interviews with patient and community engaged teams, made assessments of other platforms used by the members. The second one, Cystic Life, received what was then an active program called Pipeline to Proposal. And in that engagement or capacity building mechanism, there were 3 tiers. And this was really about developing partnerships. So we talk about engagement as if folks could roll out their bed and meet somebody that could engage with them. But what we really know is that that early engagement, or pre-engagement, if you will, is very critical. How do you form these partnerships? Those partnerships have to be funded. So we provided money to allow people to have conversations and get to know the other people who shared an interest in a particular problem. So with Cystic Life, they were able to further develop their infrastructure to develop research priorities from these conversations that they were having. strengthen the communication between the members, identify researchers who are actually interested in the same problems that they were interested, as well as medical professionals to collaborate with. And the tier 3 of that award, they chose the most relevant outcome measures and comparatory interventions and populations to target. So again, Cystic Life, and I'll come back to them at the end of the presentation, because I think that they're really exemplar. And you will be hearing from Ronnie Sharp tomorrow, who led that project. So the reason that we fund capacity is hopefully that we're building capacity to get to a research project. And this was one such example where the project team received an engagement award, 12 months, to create a network, an online community of patients, providers, and research. They developed a future roadmap for research, and they had as one of their key partners the COPD Foundation. They took what they did in the engagement award and the capacity building, and then transferred that over into a research award. So this is a kind of the ideal way that we hope that this mechanism is used, to start with engagement, end up with a fundable project. So in their project, it was an observational study using Medicare data, comparing the benefits and harms of steroid use and inhaled corticosteroids. So this is a completed project, and I point this out just to kind of also show you how we are presenting information on findings of studies. If you go to PCORI's website, you'll find projects that have results have a public abstract or a lay abstract that has gone through user testing, that is in plain language presented what was the study about and what were the findings. And then there's a quote-unquote professional abstract for a more clinical audience. Also, if we have the opportunity to scroll down this page, we would also find if there were any articles that were generated from this study, and all the links, if there were any tools developed by this study, and all the links that would give you a comprehensive snapshot of the products that came out of the project, as well as the project itself. So a little bit about me, because I like to give some context, just so you kind of understand the kind of path that a number of people walk when they come to this work, as John mentioned. So that's my daughter when she was quite young, and her name is Maya, and Maya was born with pulmonary hypertension. She had a very rough entry into the world, and she was on ECMO, if anyone's familiar with ECMO, for a long time in ECMO life. And she was the catalyst to getting me involved in this work. So Maya, for the first 3 years of her life, spent a considerable amount of time in the hospital. And I was one of those people who would show up at grand rounds because I needed my mind stimulated. I would start having conversations with everybody. I eventually started working at our pediatric hospital, and I was the first parent navigator there and helped build that program up to work with families that had medically complex children. So from that work, I began meeting researchers. They were on this other floor, right? Kind of hard to reach. It was like, what is happening on that floor? And so I started talking to investigators. By that time, I had also become very active in the Patient and Family Advisory Council at the hospital. And I co-led that council. And that gave me another entree into meeting researchers and working on QI teams. And my first project was an asthma study, and I'll show you a picture of that in a moment from one of the other stakeholder partners that was involved in that study. And my second project was one that focused on parent navigators in neonatal intensive care unit settings. So, excuse me. What I found very interesting was that terminology was used I had never heard before. Someone called me a co-investigator, and I was like, that sounds good. I don't know what the heck that means, but the PI loved to write about that in all the reports that we had. A patient, a mom, a caregiver who was a co-investigator. And so I understood that it had relevance in his world, but had no idea what that really meant, or what were the expectations of that role, or where I could insert myself, where was appropriate. And it was one of the many learning lessons that I took away from that was about the importance of communicating roles and responsibilities when you're engaging with families. So let me see. So on this study was, we had 4 other moms as key stakeholder representatives. We also had a representative from I live in Washington, D.C., and from the DCPS, the public school system. They handled all the nurses that were assigned to DCPS locations. We had a lawyer who worked in helping families that had complex needs get those needs serviced. We also had an insurance provider. And so this was a situation where there was a lot of perception by the moms who were a part of that research team. So like, how does this work? Because you have certain credentials and we don't. So one of the first things that I did as the engagement lead was to ask everybody to take a picture of something in their life that they thought represented a challenge to asthma. This is an asthma study. And so these were 4 of the pictures that came back. And I think they tell a very interesting story. Because the first picture that came back actually was from the PI, who spent a lot of time also working in the ED. And one day, a family came in, and inside of the spacer, if you can see there's a roach. And so that instantly gave him some insights about what this family may need. And so this was a clinic that also made linkages for you. So housing and other needs that have been unmet. And so he was able to link that family to some services. The second picture is actually my picture. You'll see in the back there's an enteral feeding pump. My daughter was on a feeding pump up until 2 weeks ago. And this is like a short list of medications that she was using at that time. And I put well positioned back there, my voice matters. The third picture was actually from one of the clinicians who was at the table. And I remember this so clearly. She said to our group, well, I was thinking about this as I was driving home, that what if I was stuck in traffic during rush hour and my child had an asthma exacerbation? And she was being very emotional, thinking about what this might mean for her. The parents at the table thought, well, we're at the bus stop. You have a car. And so it really brought to light these differentials. And it was, as best it could be, like this leveling. It was talk about like authentic conversations. And then this last picture was from one of the moms saying, look, I've tried, those are Nicorette gum pieces. She's like, I've been trying to stop smoking, but the stress in my life around housing, all kinds of financial stressors, this is what I find myself doing late at night. And again, a very authentic, revealing of herself. Very risky, some might say. So these are the kinds of conversations, just to get a barometer, where are people coming from, and the different perspectives that they can bring to the table because of their positionality. So that's a picture of, that's me in the back, and that is one of our partners on the study, Tiara. And we're doing this mind mapping exercise or journey mapping of like, where did you give input? What was the experience of it? Tiara right here in this picture is laughing, but I have to tell you that, so we were in part of an asthma evidence to action network is what we called it. So PCORI had funded, at that time, probably about 12 studies on asthma. And we had a patient partner affinity group. So whenever we would meet on an annual basis, all the patient partners or family caregiver partners would meet up and we would have discussions and activities. This session, although Tiara is laughing, it actually turned to tears because there was a moment where I asked, and you can kind of see it up in the corner, you can see the beginning of the letter T and R. I was like, something halfway through it, as I was facilitating, I was saying, something is not being said in this room. What is it? And so I said, I'm going to put trust up here. And if you have any reaction to that word, please just take your Post-it and put your comment by it. By the end of the session, it was the most populated place on the sheet. And that's because while the investigators, they were saying, oh, engagement is working so well. We are getting, all this valuable input. They're redirecting the study. They're helping refine the outcome measures and what have you. The partners, no one had really asked them how they were doing. And so they were like, this thing that's still in the room is that I'm not still at a point where I trust you. I feel like you're kind of leveraging this and using this experience to better your career or to follow the money, as some said earlier. So that was, there were many positive impacts, but just to bring home that engagement can be a very emotional experience. People are allowing themselves to be vulnerable and taking the deepest part of themselves to apply it to better research. So we talk about why engage, and from a PCORI standpoint, the reasons we say that we engage is to influence the research to be more patient-centered and relevant, to establish trust and a sense of legitimacy in research findings, and to encourage successful uptake. And so we've seen different models today, and there are many of them, but the point of this is to say that engagement does occur along a continuum. From being unidirectional, you're taking information from people, to bidirectional. You're actually working together. There's an exchange. There's a sense of reciprocity. So, but the question becomes, so we know from an organizational standpoint why we engage, but why do stakeholders engage? What's in it for them? And this is what we learned when we conducted a study of 255 individuals who completed a survey who were stakeholder partners on some of our research studies. And this is what they told us, that they're motivated to improve people's lives, just very altruistic. They wanted to improve the health of people in general, and they wanted to improve the care experience, including patient-provider communication. They wanted to have a voice. For so many communities, the idea of actually having a good conversation in their minds with their provider is a stretch. And they feel like they've never been asked before, or there's been historical injustices against certain groups that make them feel like alienated and marginalized from research. So many people express that they wanted to have a voice so they could be heard Also, at the top of the list was addressing a gap for underserved communities. And they wanted to support projects that would benefit the communities that they reside in. We also heard, in terms of motivations, that people had a basic desire to learn. They're very interested. Often, people who are very curious, they want to learn more about their condition and how they may be on the cusp of learning about new treatment options. They want to learn just broadly. There's also people who are motivated because they really believe in the intervention. So maybe they had it once, and they felt so strongly about its potential, they want to see it spread and disseminate. So it's kind of an interesting internal conversation that we have among my colleagues when we're looking at research studies, proposals. One of the questions we ask ourselves, is there a representative for each treatment arm? So if you strongly believe that occupational therapy will help you return to work faster, maybe there are people who, and maybe it's actually the dosing of it, that it happens weekly over the, right after hospitalization as opposed to biweekly. I'm just making something up. That we want to make sure that there's people who represent both viewpoints and both experience. So what are people getting out of this experience? The number one thing that we heard was that building new relationships was vital. It was so important that it was transformative for many people. As you can imagine, you have certain conditions. Conditions may isolate groups. So being able to interact with people who had similar experiences was one of the main impacts. Making a meaningful contribution. As this quote represents, this person is saying that as an older citizen with mobility limitations, this involvement has allowed me to contribute to the better good. Now, there may be, throughout the course of, through other areas in that person's life, where they feel like they are not being a contributor, or they're not appreciated for that, but this gives them that opportunity. We also see that the important impacts for people is a greater knowledge and enthusiasm for research, for making those improvements to health and healthcare, and developing skills and professional opportunities that they would not have otherwise had. This person here, she was a stakeholder partner in a study in North Carolina. During that experience, she wrote a book. She became a self-published author. I would see her at different conferences where she was co-presenting with the investigator, and her doors open, and we've seen this in other places too. So why does all this information, why does it matter? Why does understanding motivations and impacts matter? It matters because this matters to your partners. So if you're trying to promote research engagement opportunities, it's very helpful to know what motivates people to do it, so that you can speak to them on those terms and invite them in on those terms. It helps with creating incentive structures that are meaningful to partners. In our compensation framework, we not only talk about financial payment, but we also talk about thinking much more broadly. Maybe if you're at a medical center at a university, maybe it's computer time or some professional workforce development opportunities, or helping them with a resume, or it's access. So we have to think more broadly about what incentive structures can be. It also allows you to have the conversation about expectations. And so if someone is really motivated by creating new relationships, and maybe you're meeting virtually for all of your opportunities, maybe that's not, and they really are looking for in-person contact, maybe that's not the project for them. You also want to be able to talk about what is the value of what they've been able to contribute, and talk about it in terms that are meaningful to them. So I have a a sheet that I'm going to give out later on in the workshop, but it talks about facilitators and challenges to engagement, and we've heard a number of them already. But just to recap, that one of the primary challenges is having different expectations and goals about what engagement should do. The time it takes to build trust, the different needs when you're working with not just patients and carers, but also clinicians, stakeholders, and policyholders, and others. All those different stakeholder groups have different needs. So balancing that and scheduling is a huge issue that comes up about when people are working with engagement. So just a few tips really quickly. Have clear goals and objectives for why you want to partner. Choose your partners wisely. It may not be that the people that you're closest to. It may not be your patients if you're a provider. It may be stretching beyond your own networks and your own comfort zones to find the right partners for your project. Up front, define the roles and responsibilities. Prepare your partners for research. Do that like the PACER program and other opportunities that are here, take advantage of those. People do not walk into this role understanding what it is or what they need to know. But they certainly, when they hit a bump in the road, they know that they feel uncomfortable. But also prepare the study teams for engagement. There's a lot of focus on preparing your stakeholders, but also prepare your study teams, because not everyone may be interested in pursuing engagement with the same zeal that you may have. Select someone to manage those engagement activities. It doesn't happen without someone who is coordinating it and keeping an eye on it and managing all of those relationships. Budget for engagement, we've heard. And we rely on these P-Core principles of reciprocal relationships, co-learning, partnership, trust, transparency, and honesty. And so by using those and keeping centered on those, it will inform the relationships on how you interact. So just in closing, I provided some resources that we have on our website. And some of them are related to research resources that will help support engagement. And then the last one, the updated engagement plan, is a really useful tool, or people are finding it to be a very useful tool, on how to think about operationalizing engagement. So there's the one thing about, like, for a funding proposal, you're conceptualizing it. Okay, but now you're awarded. What are you going to do, and how are you going to do it? And the updated engagement plan provides a way of thinking about that. We also have the Engagement in Health Research Literature Explorer, where you can go on our website and search for articles on engagement. You could search by condition, you could search by planning stage, and we have over 1,000 articles in that repository right now. We have the Ambassadors Center, which is, the ambassadors are our volunteer network of people who are interested in moving the needle in engagement. Many of them have served on research studies as engagement partners. Many of them serve on our advisory panels, but they are a great active group, and you can go there and query by geographic location if you're interested in doing a study that is connected to a US-based site. You can, there's also a great active communication platform that they're actively in communication. So I wanted to bring us back to Cystic Life. Cystic Life, as you may recall, received one of our P2P, or Pipeline to Proposal Awards, and really direct you to take a look at that site when you have an opportunity. From what I understand, it's over 9,500 members strong. And I'm going to close with Ronnie Sharp, who is the founder of Cystic Life and who will be a presenter on the patient panel tomorrow.
Our project for the Pipeline to Proposal was to establish a patient-centered research community for cystic fibrosis. And for us, what was even more important is to make it a patient-driven research community. As a patient, I've been involved in research studies, whether they were clinical, whether they were QI projects, but to actually have the opportunity to drive this research project as a patient, this is certainly my first experience driving the research from A to Z. I think the biggest gap in research has always been patient-centered research was thought up as eventually we'll get the patient to the center, and eventually our ideas will trickle down into the patient, and so we'll call it patient-centered. This has given us an opportunity to be the creators of the experience and the structure by working with, most importantly, other patients in the community, and then we choose who to bring in and drive the research from the inside out instead of from the outside in. When we described the project to our patient community, the response was greater than I could have ever imagined. I mean, our email had the highest click rate of any emails we've ever sent out. And so I think just the biggest thing I've learned is you got to be prepared when you are showing something new to your community, that the response could be even greater than you anticipated. And now what are you going to do with that response? And how are you going to harness that passion and put other patients in the best position to drive this research along with the community?
So I can't think of a better way to end it. So thank you. If you have any questions, I'm happy to answer them.